In this section, we will talk about the antibiotic teicoplanin. It's a lipoglycopeptide, very similar to vancomycin, but it came almost 3 decades later. Since 1986, it's available for use. It inhibits cell wall synthesis, very similar to vancomycin. It binds to the DLR sequence and inhibits the synthesis of peptidoglycan. It's active only against the gram-positive bacteria because it is unable to penetrate the outer membrane of the gram-negative bacteria. It's extensively used in Europe and in Asia, but it is not available for use in America. So you will find a lot of guidelines which do not mention about teicoplanin, and I have shared a section on the MRSA guidelines 2021 issued by Britain, which talks about teicoplanin use vis-a-vis vancomycin. The most striking proposition of teicoplanin is it's less nephrotoxic, or it's considered less nephrotoxic, and so it might be a choice where nephrotoxicity is a concern. Therapeutic drug monitoring is advised, probably because it's in the same line as vancomycin. So here also it is advised that we do the therapeutic drug monitoring, and you can check the trough levels as was done with vancomycin, but the better is looking at the AUC by MIC ratio, and roughly to remember it's just the double of what is advised for vancomycin. The uses are for MRSA and for enterococci. So if only the bugs are resistant, then only we consider the use of teicoplanin, otherwise we use more conventional agents. In serious infections like bacteremia and in CNS infections or meningitis, vancomycin is preferred. So there it has consistently scored better than teicoplanin. In all other conditions, teicoplanin may be considered as an alternative. For pneumonia, linezolid would be one option we should always consider. It undergoes little metabolic change and is excreted by the kidneys. The dosing is standard, is 400 milligram, 3 doses 12 hours apart, and then we continue with 200 to 400 milligrams daily. But one may consider 800 milligram loading dose and then 400 milligram twice daily for 2 days, that is almost 5 doses, to reach a steady state level faster, because we know the therapeutic efficacy of the drug is dependent on a steady serum concentration. It's very minimally cleared by dialysis, and in the therapeutic armamentarium it's an alternative to vancomycin, and the most attractive proposition with teicoplanin, it's less nephrotoxic. But when we have a serious life threatening bacteremia, then vancomycin is preferred over teicoplanin.